Let's talk about cholera. But first, let's talk about you. Okay, this is you, and this is your tummy. Let's focus here. From your skin to your guts, we have the fascia, muscles, and peritoneum. Okay, after that, we have the small intestines. Let's zoom in on them. Small intestine's main job is to absorb as much nutrients as possible, and these include electrolytes. Now, let's look back at a little bit of osmosis. The trick is to remember water likes to move where there's a lot of electrolytes. So, sodium counts, but also chlorine, bicarbonate, potassium, and all the other electrolytes as well. So, why do I need to tell you all this? Well, if you just wait. Okay, wait. Okay, I'll tell you. So, let's talk about this guy. Vibrio cholerae 01 and 039 are comma-shaped, highly motile, gram-negative bacteria with flagella. When it's ingested, and if it survives your stomach acid, it will swim into the intestines. But why are we going to ingest it? Well, that's because of its reservoir. This is where the pathogens chill before they're picked up by a susceptible host. We'll talk more about reservoirs later. Okay, so the cholera is in the intestines, and here it will use an exotoxin. But wait, what's an exotoxin? Well, let's break down the word. Exo means it goes outside, and toxin means it's something that's going to damage something else. So, an exotoxin is a chemical that's thrown outside of a cell that can damage its surrounding area. The toxin has two parts, A and B. When the toxin is thrown, B binds to proteins outside of the cell, and when the B breaks down eventually, it splits A into two parts, which activates part A of the cytotoxin. Now, A, which is activated, is in the cell cytoplasm and triggers an enzyme called adenylate cyclase and makes it work harder. By making it work harder, the enzyme is going to convert more ATP into CAMP, which is going to make the CFTR receptor, which you can remember from the cystic fibrosis video, makes the cell push out more chlorine. Where chlorine leaves, sodium leaves, and where sodium leaves, water leaves. And because of all this water leaving the cells and not getting absorbed, we get signs and symptoms. So we get our profuse watery diarrhea, which is going to look like rice water on appearance. This is a classic description of diarrhea with cholera. And because it's an infection, we're also going to get fever. And another way that the bacteria likes to spread is through vomiting. And we get the main cause of death, which is dehydration. So why can dehydration kill somebody? This is because of less electrolytes as a result of vomiting and excreting all of them out of the body. So as a result, the body might undergo metabolic acidosis, hypokalemia, and hypovolemia. Metabolic acidosis is because might not be any bicarb left in the system, and as a result we might see that the body generally starts to function less efficiently. Hypokalemia can be seen because of, again, potassium being dumped out of the system, resulting in cardiac issues, and the hypovolemia, which is because of the sheer volume being lost through vomiting and through the diarrhea, that causes the body's blood pressure to essentially start to tank, and the heart will have to compensate by working harder, which it will struggle to do because of the added hypovolemia. We understand what to look for, but why would someone get it in the first place? Can it spread around? Is it contagious? And what is its mode of transmission? Okay, pause the video and try to answer the question. Okay, here's the answer. Yes, big time. Cholera is seen a lot with people who drink water in unsanitary conditions, and this is its reservoir, which we've already mentioned. And this can be seen a lot in underdeveloped rural areas in especially third world countries. These water sources can be unsanitary because there's probably a lot of poop in the water. People can also forget to wash their hands, and their hands might come in contact with some of the poop as well. So we say that the main way of the pathogen spreading is through the fecal-oral route, because a lot of the cholera, which is in the poop, might find its way through any of the orifices in the body, like the mouth, the eyes, the nose, etc. Now let's say we've got somebody who potentially has cholera in our A&E. What are we going to do? Well, we can do a stool microscopy and cultures, as well as a rapid dipstick test, and some basic bloods to get an idea of the severity of the cholera through urea and electrolytes. But through oral rehydration therapy, which is used through pre-prepared sachets of 0.9% saline with 20 millimoles per liter of potassium, as well as cooked rice powder solution about 50 to 80 grams per liter. Oral erythromycin and or ciprofloxacin has been shown to reduce symptoms by giving these at a 1 gram dose, as well as zinc tablets to help with rehydration. Yet, of course, the best treatment is going to be prevention through good sanitation by washing your hands, having a good garbage disposal system, and a good sewage disposal system, and education on the spread and prevention of cholera. Having good cooking methods, such as cooking all your food very well and eating it hot, making sure you peel all your vegetables, and avoiding shellfish.